Good evening. My name is Dr. Shakti, and we are going to be continuing with our cardiovascular system. Uh, Today's topic is going to be a little clinically oriented topic. A lot of questions come from this topic, especially as part of essays, and of course, short notes are also there. So we're going to be talking about your hypertension, hypotension, and different forms of shock. The shock by itself is a very important question that is often repeated. Okay. So out of this, shock is the most important question. So you can take a look at the different kinds of questions that can come. Over here, a long essay, explain the pathophysiology of hypertension, including its causes, effects on the cardiovascular system. So oftentimes, just like this won't come as a long essay at your level, but I put down all the points for you to write in case they ask a question like this. Otherwise, usually long essay from this is going to probably be coming from shock. Okay, but just in case, I put enough points to describe hypertension. And apart from that, we have described the different types of shock along with the pathophysiology. There's another question, discuss hypotension and the physiological mechanism that compensates for low blood pressure. So here, mostly, we have to talk about the compensatory measures for low pressure. Okay. Then clinical implications of uncontrolled hypertension. So if hypertension is persisting, eventually what does it lead to? What are the complications that arise as a result of that? That is what we have to talk about here. And then what are the primary symptoms of shock again? Define orthostatic hypotension. So this is one peculiar thing out of the lot that you will have to separately explain. What is orthostatic hypotension? And then we'll go on to briefly explain the role of diuretic. So then basically we have to talk about different treatments of hypertension. And out of that, diuretic specifically also can be asked as a question. All right. So basically shock is a very important question. Hypertension, what it is, pathophysiology, complications, and of course, how do you treat it? Okay. And what are the compensatory measures that we have already covered in the previous class, but we'll go through it briefly today. Okay, so we'll start off with hypertension. So hypertension, first we have to understand what is hypertension and how to define it. So according to the previous classification, JMC 7, hypertension was told to be anything above 140 millimeter mercury of systolic blood pressure and 90 millimeter mercury of diastolic blood pressure. Okay. The point below that is around 120 to 139, was called pre-hypertension systolic, and diastolic as 80 to 89. So this is what for many years we've been following, just that, in recent literature, some changes were seen and they modified it to JMC 8. Okay, so in JMC 8, what did they do? They changed the nomenclature in a way that now pre-hypertension, which was 120 to 139, is no longer like that. Instead, it is 120 to 129 systolic BP. And diastolic BP, even with less than 80, it becomes pre-hypertension. Okay, in this category. Stage 1 hypertension is no longer above 140. Instead, from 130 to 139 by itself is stage 1 hypertension. And diastolic, it's no longer 90 to 99. Instead, 80 to 89 is diastolic blood pressure. Okay, stage 2 is more than 140, not more than 160, more than 140. And it's not 100 over here, it's 90. So ultimately, according to the current classification, how can you define hypertension? That is more than or equal to 130 systolic blood pressure or 80 diastolic blood pressure is the cutoff for telling it is hypertension. Okay, that is according to JMC 8. In case you want to still remember the previous one, you can give it as JMC 7. Okay, because if you take JMC 8, one of the issues is a lot of people, especially in Indian population and all, so a lot of these studies were done abroad. You bring this kind of setting to an Indian population, you will see that a lot of people are hypertensive, and then you'll have to start treatment and all that. So, it has its cons and pros and all. People still in India tend to use JNC7. Okay, that is exactly why I've given both of this option to you. Okay, and try to write down both of these options, because some examiners see this old one and they're like, okay, why you're not updated? JNC8 is now there. I'm not going to give you full marks. All right. And then even if you write JNC8, but like it's not some people will be like, oh, it's not applicable to our population. People clinicians don't use this. So why haven't you written JNC7? So to avoid all that, just write both of them and just give the heading JNC7, JNC8. This is the quota, this is the quota. Rest is up to the examiner. Okay, you know both the things and you just have to write about it. Okay, so next is, how does a person develop hypertension? That is, your blood pressure is increasing. So there are environmental causes, there are genetic causes. Most probable causes are environmental causes. It includes things like obesity and weight gain and all. It's seen that increased dietary sodium chloride by itself can result in hypertension, and along with that, decreased dietary potassium and calcium. Then alcohol intake, psychosocial stress, decrease in physical activity. These are all environmental factors that can eventually result in hypertension. And genetically, Mendelian forms of mutations are very rare, less than 2% actually. Beyond that, whatever genetic influence, we call it usually polygenic. So some sort of underlying genetic predisposition will be there. Along with that, when the environmental influence also comes, everything mixes together in order to result in hypertension. So we generally say some sort of a polygenic influence, both environmental with some predisposing genetic will make some people more likely to get hypertension. Okay. So again, one question I want you to think of is sodium chloride. Why sodium chloride? Because more sodium chloride you take, more sodium chloride is in the system. What is going to happen is, along with that, water is also going to come in. Wherever sodium chloride is there, water is going to come in. So sodium chloride with water will increase the volume. Okay, so increased volume is there. Usually, normally in pressure natriuresis, all of that happens and removes that excess. In some people who have a genetic predisposition, and if natriuresis is not happening completely, then what will that result in? Little bit of increase in the volume. One of the ways by which the body will respond to it. Okay, eventually the body will try to increase the vascular resistance and all that. So like that, eventually you see these people developing hypertension. It can be a volume related one or even otherwise. Okay. So these are just risk factors for your hypertension. So this is something we were talking about in the previous class when we were talking about BP. So when you're talking about BP per se, you have to think that BP is a product of cardiac output and peripheral resistance. Cardiac output is because of stroke volume and heart rate. Okay, peripheral resistance is based on the vascular structure and the vascular functions and all that. Okay, so based on that, we have cardiac output, peripheral resistance. Cardiac output is stroke volume and heart rate. So these are all different determinants for your BP. Okay, I'm not going more into depth of this because we previously mentioned in the last class. Now, one thing I want you to understand from here, we're going to recap the entire BP regulation through this, whatever is relevant to our topic today. So when there is a change in the BP, especially when there is a fall in the BP, what will happen? Baroreceptors detected. So one of the ways baroreceptors detected and do some modification is 1 through beta, 1 sympathetic. So beta 1 sympathetic will now go act on the heart rate. Heart rate increases, that will result in increased cardiac output. Okay, apart from that, beta 1 sympathetic also increases the force of contraction in the ventricular muscles, resulting in increase in the stroke volume. As a result of both of this, either or both of this, cardiac output increases, systolic BP increases. Okay, so this is one thing that can happen. Apart from that, through your sympathetic nervous system, through alpha-1 receptors, it can result in vasoconstriction. Vasoconstriction will now increase the peripheral resistance. Okay, so that vasoconstriction can result in increase in the peripheral resistance. That again increases the diastolic BP. Now, apart from that, in a long-term setting, when there is a fall in a BP, your RAS system gets activated, renin-angiotensin, aldosterone system. So, over the three modes of stimulating it is there. One, the sodium chloride level. How much sodium chloride is taken in, especially at the level of thick ascending loop of Henle. Over there, there's a structure called macula densa. So, over there, you detect. Okay, so that is one thing that can stimulate. Second thing, in the efferent arteriole, how much blood is there? Okay, based on that, the pressure or the stretch of the receptor over there will be detecting it. So that helps in release of renin again. Then through again sympathetic stimulation, that is through beta 1, it can result in release of renin. So ultimately, regardless of which method, it detects that okay, in the efferent arterial level, blood is less. Okay, or the amount of sodium which is there by the time it is reaching thick ascending limb of loop of Henle, the distal part, you understand that okay, it's time to release renin because sodium water is not adequate. Okay, or directly sympathetic stimulation. As a result of that, what will happen? Finally, renin, angiotensin 1 becomes angiotensin 1, angiotensin 1 becomes angiotensin 2. Angiotensin 2 will act on its receptor. It has two receptors, angiotensin 1 and angiotensin 2 receptor. So generally, these activities are mediated through angiotensin 1 receptor. Angiotensin 1 receptor. Okay, so actually, the angiotensin 2 will go and bind to the angiotensin 2 1 receptor. All right, so that receptor will result in vascular function, that is vasoconstriction. Again, that increases the BP. Okay. Then what happens? This through the angiotensin receptor, it can directly result in sodium water retention. Or the same thing can go and result in aldosterone release from the adrenal medulla, which can also result in salt and water retention. So ultimately, because of salt and water retention, either through aldosterone or through angiotensin 2, will result in increase in the stroke volume. Okay, so angiotensin also has a role in vascular remodeling. So the structure can be altered and can result in vascular remodeling in the long term as well. Okay. Apart from that, certain elements like, changes in the immunity, inflammation, which is there, any sort of oxidative stress resulting in free radical damage and all that can result in vascular remodeling and can instead increase peripheral resistance and increase the BP. Okay. Otherwise, in the vascular structure also, if, for example, its compliance is affected, as in it becomes stiff. Okay, like arteriosclerosis. In that instance, also peripheral resistance is increased. Okay. Or another thing, simple, when you talk about the vascular structure, you can think of this formula. Resistance is directly proportional to 8 eta L by pi r raised to 4. So if we look at the radius, it is 4 times to the power of 4 and inversely proportional. Okay, so when the radius changes, accordingly, the resistance is also changing. Okay, so these are all determinants of BP regulation. And hence, these are all the things that can be affected in order to produce hypertension. Okay, and these are again the same places where you can treat for hypertension. And, whenever you think of that question which was there, hypotension, in hypotension, what are the regulatory measures that happen? These are the regulatory measures that happen. Okay, all of these measures that I just mentioned, with this diagram, you draw and explain, and you have the answer for that. All right. So once that is done, next is what are the different types of hypertension that are there? So most common type of hypertension is your essential hypertension. Okay. 80 to 88%. This is from Ganon's textbook. Harrison's also talking about like 80 to 95% of essential hypertension. Then apart from that, there are other causes. So what we call as primary. So sometimes the questions might be coming something related to primary or secondary. So this is primary hypertension. Okay. Apart from that, some known cause that will be all examples of secondary hypertension. So what is primary hypertension? What is secondary hypertension? Ultimately, what it's saying is, in essential hypertension, we do not exactly know what is the pathophysiology. There is no, proper pathophysiology. It's actually a group of disorders which are not related to one another, which can eventually result in hypertension. And it's not very easy to pinpoint as to, okay, this is the cause. Okay, right now, with our current technology and understanding, that is what we have clubbed it under. All of these things, we do not completely understand how it is happening. Randomly, it's happening for some people, that is essential hypertension. Apart from that, some known cause which is there because of some secondary thing. That is secondary hypertension. So in secondary hypertension, it can be a problem in the renal system. Okay, especially in the renal system, it can be a renovascular problem or a renal parenchymal problem. Okay, this is where we talk about two terms like gallbladder, one kidney, two kidney hypothesis and all. We'll come to that. Then we have endocrine. So again, in the endocrine system, if you notice it, we are primarily dealing with whatever we were looking at in the previous page. So one thing we were talking about, sodium water retention, aldosterone. Okay, so here aldosterone is excess. So primary aldosterone, that is one way by which it can influence it. Second, Cushing syndrome. Cushing syndrome again, glucocorticoid. So aldosterone is some type of mineralocorticoid. Okay, it is a type of mineralocorticoid. Just like that, Cushing is because of glucocorticoid. So in the development, you see that glucocorticoids have some sort of mineralocorticoid activity as well. That is why even in Cushing syndrome, when glucocorticoids are excess, that will result in some sort of mineralocorticoid activity as well. Apart from this, we have pheochromocytoma. That is basically increase in your epinephrine, norepinephrine, the medulla. Adrenal medulla is getting affected and it is releasing a lot of your epinephrine, norepinephrine, which is basically going to increase your sympathetic activity in the body. Sympathetic activity, we were saying earlier, how sympathetic activity through beta 1, okay, in the heart, in the stroke volume, or alpha 1 through the vascular structure. Ultimately, it is all resulting in increase in the BP. And by increasing the RAS synthesis also. Ultimately, sympathetic system is stimulated a lot, it will result in hypertension. Okay, estrogen treatment called the pill hypertension is also. That is again, in the same thing. This does have a little bit of activity similar to this. Okay, then apart from that, some miscellaneous functions, like for example, coarctation of aorta. Coarctation of aorta, again, the blood that is coming, getting ejected will be less as a result of that. And whatever baroreceptors get activated, every sort of regulatory measures get activated to increase it. Although there is adequate blood, but it's just not coming enough because of a coarctation in the aorta. Or an example is the Little syndrome, where the epithelial sodium channel activity gets increased, reabsorption increases as a result of that. More salt and water will be there in the system. Okay, so one is the essential hypertension. We do not really understand, how it is happening. It is a group of disorder which is there, which is having the same phenotype of your increase in the BP. We have endocrine causes. Okay, aldosterone, glucocorticoids, like Cushing syndrome, sympathetic increase activity, pheochromocytoma. These are all endocrine causes. And we have miscellaneous causes like coarctation of aorta, some things like Little syndrome and all that. Okay, this is just a initial description. Then we have renal hypertension. Renal can be either renovascular problem or a parenchymal problem. Anywhere the renal parenchyma is affected. What is the function of kidney? Kidney function is to filter and excrete urine or decide how much needs to be excreted and kept back. When that is not happening, if there is some parenchymal problem as a result of which it is not able to excrete any urine, in those sort of disorders, what happens? Salt and water gets accumulated more and more, resulting in hypertension. Okay, because it's not getting excreted. Or a renovascular problem. In a renovascular problem, what is happening? We have a kidney over here. We have another kidney over here. And we have the circulation which is going. Renal artery. Now, at this point, we have the efferent and the efferent arteriole and the renin-angiotensin mechanism. So over here, if we were to clip over here, put a clip over here, then what is going to happen when you put a clip over there? This is not going to get enough blood supply. When it's not getting enough blood supply, what will happen? This efferent arteriole is not getting enough blood supply and the renin-angiotensin system is activated, resulting in the entire process, which will ultimately result in salt and water retention and vasoconstriction everywhere, resulting in hypertension. Okay, so this is essentially your renovascular problem. This also happens in two ways. There's a one kidney or two kidney format. This is a two kidney with one getting affected. Okay, another thing is, the person has only one kidney and whatever is going, the other one is not there. This by itself is narrow. Again, the sort of effect will be similar. The only thing is here, because of decrease in the flow over here, more of water will be retained, volume will be high here. And that is the primary cause for hypertension. Here, instead, what will happen? The renin-angiotensin mediated activity is the main cause for hypertension rather than a volume problem. Okay, because even if volume increases, the normal side will result in pressure natriuresis and result in excretion. Okay, so this is just in case somebody asks you what is gallbladder hypertension and all, because especially for vivas, after your final exam, in practical viva, I heard examiners ask about gallbladder hypertension. So for those of you who want to, answer this question and all, this is just a brief description. Okay. So here is the question: hypertension is classified as primary or secondary? Which of the following best describes primary hypertension? Okay. So, a chronic elevation with no identifiable causes. Okay. The underlying this condition, the answer for that is actually this is secondary. Rest of the things do not make any sense. So this is the one which is answer. So now two other terminologies are there. What is white coat hypertension? What is masked hypertension? So apparently, people who come to the OPD and all, 15 to 20% of the people who are having a first time hypertension. And that is because they are stressed, they are, coming to a hospital, they're stressed, they have some sort of problem. That's why they came there in the first place. So this by itself, just seeing the doctor and being in this crazy environment by itself will increase the BP of people, and otherwise they are normal. So this is called white coat hypertension, where they are actually not hypertensive, but at that moment in front of the doctor, they seem to be having hypertension. Okay, you do repeated measurements again many times, and ultimately you see, okay, person is not hypertensive. Okay, so this is what is called white coat hypertension. Then we have what is called masked hypertension. So the person is actually hypertensive, but when the person is recording it in front of the doctor, somehow it is not showing hypertension, but is actually having problems related to hypertension, and increase in the BP does happen here and there. So that is what we call masked hypertension. Okay. So just two terminologies for you to take note of. Now again, hypertension again can be any sort of problem where uh, either a increase in the cardiac output is there or the vascular compliance is. Again, vascular compliance, we are not talking about the resistance right now. Okay, this is vascular compliance is decreased. Resistance decreases means BP falls. When the compliance decreases, what will happen? There is going to be increase in the BP. Okay, apart from that, any sort of increase in the cardiac output because of all of these causes. Okay, here again, a lot of secondary causes. We already told about renal. Example, parenchymal diseases like polycystic kidney disease, some renin secreting tumors, okay, renal tumors. So these are all examples of parenchymal diseases. Then renovascular, any sort of arteriosclerosis, fibrovascular dysplasias and all that in the smooth muscle. Then we have adrenal problems we are talking about, that is aldosteronism, Cushing syndrome, okay, and there is a group of other disorders. These disorders, these are actually because of some genetic mutations. Usually it happens, and of course your pheochromocytoma as we are talking about. Then cortisone we talked about, obstructive sleep apnea, preeclampsia. So this is again a type of increase in the blood pressure that happens during pregnancy. Then can be a neurogenic problem, psychogenic can be there, or some other problem like polyneuritis, dysautonomia, familial dysautonomia and all that. Then endocrine problems, hypothyroidism, hypercalcemia, acromegaly. So actually, see that in hypothyroidism, we usually see increase in the BP. Sometimes in hypothyroidism, increase in diastolic BP can be seen. Otherwise, generally, when we think of hypertension, we think of hypothyroidism. Then giving medications by itself, like estrogens we are talking about, or you give, excess aldosterone, glucocorticoids, sympathetic. Okay, all of that by itself can result. Otherwise, some Mendelian forms of hypertension are also there. Like, for example, some of these things that we're talking about. Okay, so finally, now that we talked about the different types of hypertension, how can you treat hypertension? So main thing is lifestyle modification. So you have to maintain, these are again points you have to note down and write if a question is asked about treatment of hypertension. So maintain an ideal body weight, usually less than 25 BMI, aerobic physical activity, smoking cessation. Okay, so aerobic physical activity means you walk at least 30 minutes every day, or you're doing much more intense activity, you can do it less frequently also. Like for example, 20 meters of running, jogging for 3-4 times a day, a week will be more than enough in that case. Then smoking cessation, because smoking is nicotine that has variable effects on the vascular structure. Diet, what do you call a DASH, which is dietary approach to stop hypertension. So what you do is fruits, vegetables, low-fat dairy products. You reduce the saturated and total fat. Limit the salt intake, how much? Less than 6 grams per day. Okay, and give adequate potassium, because in risk factors we had seen how salt intake or too much of salt intake or less of potassium or less of calcium. So include calcium also. Then limit consumption of alcohol. So studies show that at least, okay, this is not like you should drink 1 or 2 drinks per day. That is not what it's talking about. This is, at least the cutoff like that. So if we consider one drink to have around 14 grams ethanol, so at least in males, it should be less than 2 drinks. Okay, and females less than 1 drink per day. If you have more than that, so to have hypertension. Okay, so now that all of this is done, how are we going to treat it? So one thing we can do is we can give diuretics. What does diuretic do? It inhibits some form of excretion of salt and water. Because of the salt and water retention happens. Because of that, preload increases, stroke volume increases. So this is one way by which diuretics help. Then we can use beta blockers. Beta blockers, what does it do? It ultimately reduces the heart rate. Okay, so beta blockers, the beta agonists will increase the heart rate. Beta blockers reduces the heart rate and in turn reduces the cardiac output. Beta blockers again can reduce the stroke volume also slightly. Apart from that, alpha antagonist. Which alpha? Alpha 1 antagonist. Okay, so that will increase the peripheral, that will reduce the peripheral resistance. So in hypertension, what is happening? Increase in the vasoconstriction can result in the increase in the diastolic BP. So if you give an alpha antagonist, it can result in decrease in the BP. Or you can give sympatholytics. Certain drugs are there which are called sympatholytic, which are actually alpha 2, which stimulate alpha 2, where presynaptic. Okay, at the ganglion level, presynaptically. So this is a central thing for all sympathetic activity from the central point from the brain when it's coming down at that level, at the presynaptic terminal in the ganglion. Through alpha 2, it can inhibit its own activity. Okay, so this is especially, we use central ones especially in pregnancy and all. Certain things like methyl dopa and all we use for pregnancy. Then we have everything to do with your renin-angiotensin system. Okay, so one is ACE inhibitors, the enzyme that is responsible for conversion of angiotensin 1 to angiotensin 2. Finally, angiotensin 2 is there. It should act on your angiotensin 1 receptor that we are talking about. That receptor blockade is angiotensin receptor block, ARBs, or renin inhibitors like aliskiren are there. Okay, so these things, what do? Salt and water retention is not happening. When salt and water retention is not happening, stroke volume will reduce, cardiac output will reduce. Okay, these can also, in an intermediate fashion, affect peripheral resistance because they result in vasoconstriction and it can help reduce. Okay, then there are other ways where you can put a calcium antagonist. So calcium is required for contraction of the heart. Calcium is also involved in your heart rate also. It can affect the heart rate. Calcium antagonists can also antagonize the vasoconstriction because constriction, all of that sort of things are affected over here. Okay, so calcium antagonists can affect in all of these different ways. Either stroke volume is decreased, heart rate is affected, or how much the vascular constriction is happening, that is also antagonized. Then there are dilators, which directly go and dilate your vascular structure, resulting in fall in BP. So these are all different methodologies by which you can reduce your BP. So just one diagram, I'm explaining everything. Examples for this, I'm gonna show you. Okay. So before that, one of the things is diuretic. So since a separate question of diuretic was there in the beginning, I'm just explaining it a little more in detail. So out of all of these diuretics, most often used are the ones that I'm telling you now. So loop diuretics, example furosemide, bumetanide. Okay, what do? When you learn renal system, this will make a little more sense. Okay, so until then, just bear with me by heart this. When it's time to go to your renal system and start making more sense that time. So what does it do? It inhibits sodium, potassium to chloride co-transporter in the thick ascending limb. Okay, so in the thick ascending limb, sodium, potassium to chloride co-transporters are affected. Okay, so what happens? These loop diuretics. At this level, sodium, potassium to chloride transporter, that is where it reabsorbs salt and water. When that is not happening, it goes through the urine instead. That is why diuresis. So salt and water gets wasted through the urine, resulting in reduction in salt and water in the body. Thus, BP will decrease. Similarly, thiazide diuretics like hydrochlorothiazide, chlorthalidone. So what do? In the distal tubules, not in the thick ascending, in the distal tubules, sodium chloride co-transporters are there, which are inhibited. Then we have aldosterone antagonists like spironolactone, eplerenone. So they inhibit the action of aldosterone. Okay. Then we have sodium channel blockers, certain sodium channel blockers like amiloride and all. They block the entry of sodium and sodium into sodium channels. These are especially in the distal collecting tubules. Now, one peculiarity for these two are they decrease potassium secretion. The thing is, everything else, more sodium is, like for example, thick ascending limb, early distal tubule. In all of this, when you give loop diuretics or thyroid diuretics, finally, what will happen? Extra sodium is going to reach your collecting tubules where sodium and potassium can be replaced, and sodium can come back and potassium will be exchanged, and it will end up resulting in a lot of potassium excretion. Okay, which can result in problems with diuretics, especially cardiac problems. So to prevent that, in people where potassium is less and all, you can use something which can decrease this potassium secretion. Okay, so these are all different ways by which your diuretics act. The other treatments like diuretics, apart from the beta blockers, these are just examples: atenolol, propranolol, metoprolol. Labetalol, carvedilol have, not only beta but alpha blocking also. Alpha antagonists, specifically prazosin, doxazosin, sympatholytics, clonidine, methyl-dopa and all. AC inhibitors, captopril, lisinopril, ramipril, enalapril. Angiotensin 2 antagonists, losartan, valsartan, candesartan. Renin inhibitors, aliskiren. Calcium antagonists, nifedipine, verapamil, diltiazem. Direct vasodilators, hydralazine, minoxidil. So again, how they act, everything in 2 pages before I had explained everything. This is just for you to just remember 1 to 2 names, whichever is easy for you. Try to remember 1, 2 names under each of them. Okay. So which medication class is commonly used to manage chronic hypertension by decreasing vascular resistance? So again, if you remember what I taught you, it will be easier. Beta blockers does not really have an effect on the vascular structures because beta, alpha is what is involved in vasoconstriction. So that is not the answer. Diuretics again has nothing to do with anything to do with peripheral resistance. Instead, it increases salt and water excretion. Okay. Antihistamines also does not really play much of a role in hypertension treatment. So out of the lot, the best answer is calcium channel blockers. Now, what are the complications of hypertension? In the heart, cardiovascular problems related to heart are the most common cause of death in hypertension. Seen that cardiovascular risk for every 20 millimeter increase in systolic BP or every 10 millimeter increase in diastolic BP, the cardiovascular risk doubles. Okay, so one thing is the problem with afterload. There's always going to be a higher afterload against which your heart has to pump. That can result in left ventricular hypertrophy. Eventually, heart failures can happen. Okay, then apart from that, a long-standing complication of hypertension is by itself atherosclerosis. This happening to coronary arteries can result in coronary artery disease, microvascular disease, and even arrhythmias can develop as a result of it. In the brain, very often what we see is stroke happening. As a result of increase in the blood pressure, stroke can happen. People with hypertension tend to have impaired cognition, especially in the old age. Beta amyloid deposition, it is linked to Alzheimer's disease and all that. And in a form of emergency situation, it can result in hypertensive encephalopathy as well. In the kidney, this by itself can result in renal injury, can start off as microalbuminuria, which can go into macroalbuminuria, and finally reach end-stage renal disease and all. Even peripheral arteries, as I was telling you earlier, atherosclerosis can develop secondary to long-standing hypertension. Okay, and apart from that, peripheral arteriovenous occlusive diseases also can happen. So these are various complications of hypertension. So we'll just take a look at this case scenario. A 62-year-old patient came with headache, blurred vision, shortness of breath. So headache is there, blurred vision is there, shortness of breath is there. she's hypertensive. Okay. But when you see the BP is 210 by 120. Okay, so already she's having some symptoms. Now you look at, the retina and you see retinal hemorrhages, papilledema, pedal edema. So this is an example of malignant hypertension. So when you say a person is having more than 180 systolic BP, more than equal to 180 systolic BP, more than equal to 120 diastolic BP, that is some sort of an urgency which is there, because we have to treat this. Otherwise, eventually what will happen? This can result in some sort of acute target damage. Okay, so these features in this scenario, what you're seeing is headache, blurred vision, shortness of breath can all be secondary to this. Now, when you look at the fundus, you see the retinal hemorrhage, papilledema there, which is all because of target organ damage. Okay, so BP is very high, target damage is high. This is a sort of a emergency, hypertensive emergency. Okay, so this is what you call malignant hypertension. Which of the following statements about hypertensive emergency is accurate? So as we were just talking about, there's an abrupt rise in BP with acute end organ damage. Now, a terminology called orthostatic hypotension. So what is orthostatic hypotension? Orthostatic. So this is with response to change in the posture. So when a person is lying down and suddenly getting up, okay, a fall in the systolic BP of more than 20 or diastolic BP of more than 10 after standing up within 3 minutes. Okay, so usually what happens when a person from lying down, he stands up. What will happen is a lot of the blood gets cooled down around 450, say 450 ml. 450 ml of blood is cooled down. Okay, so immediately there is going to be fall in BP for everybody. But our baroreceptors sense it, it corrects itself, and it comes back to normal. This is what normally happens in everybody. This is happening in less than 30 seconds, 15 to 30 seconds, it corrects itself. Okay, but somebody for whom this correction is not happening adequately for multitude of reasons, that is what we call orthostatic hypotension. So even after 30 seconds, it is not correcting itself. And within 3-minute period, you see that the systolic BP is falling more than 20 millimeter mercury, or diastolic is falling more than 10 millimeter of mercury when the person is shifting from a lying down position to standing up position. That is what is called orthostatic hypotension. Okay, so orthostatic hypotension most likely to occur under which of the following conditions? So as we were just mentioning, moving quickly from lying down to standing up position. That is what is called orthostatic hypotension. Now, the last point is your circulatory shock. How do you define circulatory shock? Because of an inadequate cardiac output. That inadequacy of the cardiac output can either be an absolute, or actually it is there, or relative to that person. We'll talk about it right now down. Okay, because of that, inadequate tissue perfusion is there. So either because of an actual problem with cardiac output, or even if the cardiac output is normal for the person, but right now relatively at that level, the cardiac output is not adequate, resulting in inadequate tissue perfusion. Okay, so ultimately what is the problem? Tissue perfusion is not adequate. Okay, this can happen with cardiac output less or a normal cardiac output only, but at the tissue level, still that is not able to perfuse it adequately. So this is what we call a circulatory shock. So this is how we define first. Okay, then what are the types of circulatory shock? It can be hypovolemic. Hypovolemic means volume is reducing. So say for example, hemorrhage, trauma, surgery, in all these cases, what happens? A lot of loss of blood is happening. Okay, so loss of blood is there, then blood volume reduces, preload decreases, cardiac output decreases. So this is an example of an absolute. Or, burns, the fluid plasma volume also reduces. It keeps getting used up and keeps evaporating and all. Okay. Then we have GI loss of blood, fluid. through vomiting, diarrhea. So ultimately what is happening? Hypovolemia is happening. That will result in a absolute reduction in cardiac output. And when that results in inadequate tissue perfusion, it is called shock. Or it can be a cardiac cross, that is cardiogenic. So cardiac heart is not able to pump enough. Why will not be able to pump enough? Either there's an MI, or there's an arrhythmia, or a congestive cardiac failure is there. So in all of these scenarios, the heart is not able to pump enough. Stroke volume is less. When stroke volume is less, cardiac output is less. This is also an example of absolute cardiac output reduction. When inadequate tissue perfusion is there, that results in circulatory shock. Then obstructive problem. As it passes through the chest, some sort of obstruction that is happening. Like for example, cardiac tamponade. Okay, the outside of the heart is covered by blood, for example, and it's not able to pump enough. Okay, or your pulmonary embolism is happening, or tension pneumothorax. So in all of these cases, what is happening? From your right ventricle, it goes through the pulmonary vasculature to reach the left atrium and left ventricle. In this stage, there is a problem. Ultimately, because of that also, what is happening? Absolute reduction in cardiac output is what is happening. Okay. Then we have distributive. In distributive, generally, either a neurogenic problem, anaphylaxis, or sepsis, all will result in sudden vasodilation. So over there, what is happening is there is enough cardiac output, but because of sudden vasodilation which is happening, that can result in a relative inadequacy of tissue perfusion. The blood flow will be affected, and also increase the metabolic requirement in the area can also be there, and that will eventually lead to a relative inadequacy of cardiac output, resulting in a inadequacy of tissue perfusion. So although cardiac output is okay, here the problem is at the peripheral level, where some form of anaphylaxis, sepsis, neurogenic will result in a relative reduction in cardiac output. Okay, so two terminologies, sepsis and septic shock, sound similar, but it's not. So the main difference is, when infection is there, host response is affected in sepsis. When a type of sepsis only, sometimes circulatory system is also affected. Okay, so how can you say the difference? In septic shock, you constantly require, there is an infection and the person constantly requires some sort of vasopressor therapy to keep the BP up. Okay, simple sepsis is infection with sepsis-related organ failures. So in the pathophysiology of cardiogenic shock, which is the following factor, is most directly responsible for decreased cardiac output. So decreased stroke volume due to myocardial dysfunction. So we're talking about cardiogenic. Okay, so that is the one that fits better into the picture, and rest of the things don't make sense. So we'll talk about stages. So circulatory shock can be first a non-progressive. Okay, in non-progressive stage, what is happening? The compensatory mechanisms in body are kicking in. They're working perfectly, and it's not progressing and getting worse. Then it starts getting worse and worse. That is progressive. So the compensatory mechanisms kept helping, but after a point, the compensatory mechanism starts failing. When it starts failing, what happens? The tissue perfusion is not adequate. As a result of that, hypoperfusion will result in metabolic acidosis, lactic acidosis, and all. Okay, that is what happens in progressive. And then it goes into a irreversible stage. By that point, cellular injury has happened, multiple organ dysfunctions happen. It is irreversible. Even at this point, you give a blood transfusion, try to bring the patient back up, still eventually the patient is going to die. So it is very essential that you understand these stages of shock, because when you see it in a patient, you'll have to understand it pretty early. You have to understand, okay, this is non-progressive right now. You can still treat it. It is going to progressive. You are supposed to pick it up and amp up your treatment. Okay, you should not wait for it to reach a irreversible stage where it's not going to help anymore. Okay, so that is why you need to learn these stages very importantly. So you can see here, hemorrhage is there, reversible phase is there, and it's coming back to normal. But it goes into irreversible, eventually the person will die. Okay, so in non-progressive, what are the compensatory mechanisms that happen? One, immediate baroreceptor reflex. Two, sinus ischemic response if it falls below 50 millimeter mercury. Thirst will get activated. Epinephrine or epinephrine will be released. Intermediate mechanism like stress relaxation that we talked about in the previous class. Renin-angiotensin mechanism is there. And we have ADH. ADH again will result in two things, that is water retention, okay, antidiuretic, and increase in the constriction of peripheral vessels. Okay, so baroreceptor, sinus ischemic response, thirst, and stress relaxation, epinephrine, norepinephrine, renin-angiotensin, ADH. All of these are compensatory measures. Again, I'm not going into detail of this because we already took 1 hour of lecture to explain all of these mechanisms in the last class. So, in non-progressive, what is happening? Hemorrhage is there, for example. This is just an example of your hypovolemic shock. Okay, so what is happening? Venous return is less. So ultimately, your BP is falling. When BP is falling, that is one detected by baroreceptors. Sympathetic response is there. Okay, apart from that, your blood flow is less, blood volume is less. That will result in activation of chemoreceptors, peripheral and central. So ultimately, as a result of all that, sympathetic response is happening. Sympathetic response, what does it do? In the vessels, it results in increase in the peripheral resistance. In the heart, it results in increase in the heart rate, increase in the contractility to increase the cardiac output. Okay, ultimately BP comes back to normal. So these are all the measures that help regulate the fall, and that is non-progressive in its nature. So sympathetic nervous system plays a crucial role in compensating for shock by. So out of all the options, the best option is this. Okay, it actually increases cardiac output, but it does not reduce cardiac output. It does not, result in renal absorption. Definitely does not result in vasodilation, only in the skeletal muscles and all. Now, in progressive, what happens? This decreased cardiac output, BP, blood flow is affected. Finally, tissue perfusion is affected. That means nutrition is not there. What does it do? Metabolic waste products and results in acidosis. Okay, apart from that, some toxins are also released. So these waste products will result in vasodilation. Okay, when this happens to the brain, that by itself can result in the vasomotor activity which is coming from the brain, resulting in vascular dilation. Okay, increased capillary permeability can also be there. So the blood fluid goes into the interstitial fluid instead. Blood volume again decreases. As a result of all of that, what is going to happen? Your venous return is going to decrease. Cardiac depression is also there because the heart is not being able to pump enough, because it's not even that requires nutrients. Okay, and it can result in ischemia and all. So once this happens, this further worsens the whole cycle by further reducing the cardiac output. Now, cardiac output is further reduced, the entire process again keeps getting worse. So this is an example of a positive feedback which is happening in shock. Okay, decrease in the cardiac output will result in some changes which further make it more difficult to reach the same cardiac output, and the body will keep trying to increase the cardiac output, and eventually it keeps failing and failing, and it's a positive feedback mechanism which is happening. So you can see here different possibilities how it can go back, can go and come back. Okay, or it goes down and it comes back, and in other scenarios it can go down, come back, but still eventually die. Or from beginning it goes into irreversible and goes different forms of that. And here also you can see once it has reached the irreversible stage, even if you give a transfusion, slightly it is improving and even coming back to normal BP, but eventually the person is going to die. Okay, this is the thing about understanding about irreversible stage of shock. So force shock, you have to do various tests. One of the most important thing is to look for lactate, because as we saw in progressive stage of shock, the lactate uh, increases. Okay. So that is one thing that you have to keep a note on. Apart from that, look for end organ damage, like renal function, liver function, cardiac enzymes to check if cardiac MI is not there or not. These helps to make sure that end organ damage is not there. Okay. And you look at, your blood gas analysis and all of these other things, like urine sediments and all, you can keep checking for. Okay. And in the final stage, even PT, bleeding manifestation and all can arise. And that is why these are all different tests that you use for shock. So which physiological mechanism is disrupted in hypovolemic shock? Okay. So here blood volume, hypovolemic, blood volume is decreasing. That is a major problem here. Shock can lead to cellular dysfunction due to insufficient oxygen delivery. Which type of shock is primarily due to bacterial infection, widespread vasodilation? So this is septic shock. So distributive shock could have also been neurogenic, since they specifically mentioned that this is due to an infection. Septic shock is the thing. Okay. Otherwise, you would have been confused between these two things if it was something to do with only this. A patient experiencing cardiogenic shock is likely to exhibit which of the following findings due to underlying pathophysiology. So in cardiogenic shock, one of the things that you'll find is, okay, so urine output will be less, and this is more commonly seen in, hypovolemic shock actually. Okay, so here basically the person is not able to give enough blood out, and it is not able to eject enough. So eventually the final urine output also reduces, and since not enough blood is being ejected, cold extremities and all. But this is more better for hypovolemic shock actually, but out of the options, this is the best answer here. Okay, so we'll just discuss about a few things about Auricle. Auricle has pre-recorded sessions which are there. All the classes are pre-recorded, made available for you to read at your own convenience. There are live classes where you can actually interact with your examiner, and the express exam module helps you prepare for the exam, where the entire syllabus is covered under 20 hours. And there's one-to-one doubt clearing sessions if that is something you need. And hard copy note sets are made available. And these notes have different types of MCQs, diagrams, trivia and all that. There are also different types of MCQ questions based on different difficulty, and not only essential for your NEET PG and FMG, but even for your university exams as well. Practical sessions are also part of the pre-recorded sessions, and these are the various subscription plans which are made available. You can use my code Dr. Shakthinag 20 for discount on subscription. So thank you for watching. You can